First of all, I want to thank everybody for for joining us today and for allowing me to speak about a program I love so very much. Prior to coming to the Middle Alabama Area Agency on Aging, I did the E&D waiver program at Chilton Showing Mental Health at the health department for approximately 15 years. We adopted the program from the Department of Human Resources and we ran with it. Over the years, I've seen a lot of things, and the one thing that is constant is change. But Medicaid firmly believes that they want a program that prevents folks from going to a nursing home. One of the ways that we receive our referrals and get clients enrolled, next please. Once someone calls in to the Middle Alabama Area Agency on Aging, they will go to and speak with the receptionist, and they will be sent over to ADRC. ADRC does a lot of screenings for all of our programs. If they find somebody that qualifies for our program, they send it to our person who screens them further. We serve, as we said, it's the elderly and disabled. Disabled covers a lot of ages, a lot of disabilities, and in the past, I've admitted someone from the age of 6 months old all the way into their hundreds. The screening criteria is basically, we are based on a health model to keep people out of the nursing home, and it's basically nursing home criteria. And there's a lot of things I could go over, but I can tell you the main ones that seem to catch everybody. That's taking medications on a routine basis. They like to say potent and dangerous injectables, but basically it says medications. And the belief is that even if you take too many aspirin, that it can be potent and dangerous. So that's one of the things that catch them. And another one is going to their medical provider, doesn't matter which one they go to, about every 30 to 60 days. So they may see them 60 to 90 days, but when you spread it out over a year, basically they're seeing a doctor every 30 to 60 days. Also, if there are any tubes involved, it can be a catheter, it could be a G tube, it could be an N tube, it could be colostomy, whatever, as long as there is something that needs to be medically taken care of routinely by a nurse or a trained caregiver. Some of them are expressive and communication disorders. It involves mobility is one of the things, and being able to transfer is one as well. So basically, they are placed on a referral file at that point once they are screened for the criteria that they meet. And they can meet it through SSI or what we call an institutional deeming process. I've had an SSI Medicaid client literally go out, screen them one day, send information to the doctor, and end up sending everything to Medicaid or ADSS or Montgomery office, and they be admitted in 72 hours. With the institutional deeming process, as we go over it, I think you'll see why it takes a little bit longer. It can take up to 3 months, and I've had some to take up to 6 months or more. It's really depends on when we get the medical back from the doctor. Once again, this is deeming versus full Medicaid. On the next slide, you can see some of the criteria. One of the things that is new to me from the other agency is Medicaid has instituted what's called an estate recovery program. And what they do is they can search and find out any piece of property that the client may own or have their name on. Say they may rent in the housing authority or the local apartment complex, but yet they share a property. Their name and a brother or sister's name is on a property as well that they could inherit. Medicaid considers themselves the payee of last resort under all circumstances. So what they would expect that client to do is to sell that property, excess property, and use that money for their care before Medicaid kicks in. And our process is exactly the same way that nursing homes look at a client that would be applying for a nursing home, which would be nursing home Medicaid. There is really very little difference. I think maybe it's a button pushed or something like that between the two. And with full Medicaid and SSI, the client has already been declared disabled. When you move over to the institutional deeming, things change a little bit and get a little more complicated. Clients can only make up to like $2,500 a month. A state recovery applies there. They can only have a limited amount in their bank account, maybe $3,000. If they have any type of insurance to assist with burial or life insurance, they will only accept a certain amount before they would deny them. And that's a mystery. I don't know how they figure that out yet. But the client would have to literally sign stating they waive the right to use the money for any other way than for their own burial. And due to the limited amount they can have in their accounts, you can understand why a little more needs to be kicked in, because, you know, nothing is decreasing in price at all. Also, in the deeming process, if a client does not have SSI and does not have Medicaid, there are instances when the children, all the way till 19 years old, they may have to be deemed disabled. And with the institutional deeming process, that means we have to not only get their financial information, but we will also have to get their medical information. And sometimes they request up to 6 months worth of doctor's notes to prove that they are disabled. The QMB and SlimB clients they've already normally been declared disabled and financially meet the criteria. So they're a little bit easier to get on the program. Like I said, I am part of the initials team. So what I do is I just go out and get all the paperwork signed and get the process started. We get a medical signed and we send it to the doctor, and he has to prove that they're medically eligible. And that's kind of the crux of the whole thing. There are a lot of doctors who refuse to sign the form stating that they don't meet nursing home criteria. Oh, move the slide, please. I apologize. Yeah, this is good. And so that medical, everything really is the crux of the medical, because it proves that they're disabled and why they need our services. When I gather my information, I paint them a picture of the home, what the home looks like. I write what if they have walkers, any type of equipment they have, if they have assistants, if they have caregivers, if they have transportation. And then I write a narrative that hopefully adequately explains to Medicaid and our Montgomery office what the home looks like and why they need the services. On this slide, you can see the information that we collect. That's really not something we need to concentrate on, but you can see how tedious the process can be with gathering all the information. The one thing I want to touch on is the home folders. That's pretty important. We put a lot of documents in there that pertain to our program, flyers, whatever information we think that they need. But I also take the time out to put as many forms as I can in there that they sign on our tablet. We know with the aging population, sometimes there's dementia, there's Alzheimer's, there's a little paranoia, and there are a lot of caregivers that really want to make sure that the people coming in the home are legit. And so if I leave everything in the folder that they have signed, they will know that it's legit and I'm not trying to take excess money, their home, or anything like that from them. So if we'll go to the next slide. How the care plans are created. While I'm there, everything is client-centered or patient-centered care plans. That means I sit there and speak with them. And after I've spoken with them at the end of my assessment, I pretty much have in my mind what I think they should receive. But they tell me what they need as well. So we come together and have a meeting of the minds and decide what services that they need. And those services are Medicaid will provide homemaker services. That's to assist with cleaning the home, cleaning the bathtub, cleaning the toilet, doing all of their laundry. And I don't know about you, but I'm getting up in age and I don't like doing those things, and they can be pretty painful. So for somebody who is really disabled and elderly, you can imagine the difficulty with that. They also run errands for them to pick up medications, to pick up groceries, because they may not have that ability to do that. They also assist with running errands like for groceries, for their medications, things such as that they may need for themselves. Then we have personal care services. The personal care services is really important because we know the majority of the injuries happen in the bathroom where they slip and fall or break a hip or things like that. The personal care person that comes in can completely bathe them or just be there for safety. And they always respect their modesty and their right to privacy and dignity, and take care of them according to the way they want to be taken care of. We also have respite services. There are two types. We have unskilled respite, which is someone who just needs to have someone with them while the caregiver runs errands, takes a nap, whatever they choose to do during that time, groceries, however they feel like they need to spend that time. It's to relieve the caregiver and prevent burnout, because we know that happens quite often, and sometimes the caregivers go in the hospital before the clients do. The other type of respite services is skilled respite service, and that's when I have a contract with someone who has nurses available, and these are the individuals that can come out and administer medications. They can feed them through their G tube. They can change their catheter, whatever they need to have done, feed them and be there for them while the caregiver handles errands. Most of the time, when it comes to most clients like that, need 24-hour care. And say if I had a client that was doing pretty good, went to church on Sunday, but just had a hard time cleaning their home, I would give them homemaker services. But with a client who is bedbound and needs so much done 24/7, like they do when they are in that type of condition, I would, of course, increase services to make sure that they would get the maximum to assist the client and the caregiver with having a break from one another. Because I don't know, I can't imagine my daughter taking care of me when I get older. We'd probably still be fighting then, and I would need a break from her, to be honest with you. But we have two ways to administer these services, which I'm very thankful for Medicaid for making a choice. Yeah, that's fine. They made the choice between providing the services through hiring agencies that have workers that can go in and provide the care. They are thoroughly screened. They have background checks, the whole 9 yards. And due to the Great Resignation and due to the nature of the job and the hourly wage, a lot of people choose not to do this for a living. So Medicaid has created another program called Personal Choices. And Personal Choices is where the client is the boss, fills out all the information that's needed, and they get a W-2, and they get approximately $10 an hour to come in and take care of the client. And the client chooses this worker so that they feel most comfortable with what they're doing. It could be a daughter, it could be a son, cousin, friend, person from church. We're not really as concerned about that as much as we are them getting the services that they need. And then next, please. All right, this is more about the application process. As I said earlier, once I get my application complete, my boss reviews it, makes sure everything's okay. We send it to ADSS for approval. We have nurses down there that look over it and make sure we meet the criteria we need to be approved. ADSS approves the full Medicaid client, so that's why they get on so quickly. But when it comes to an institutional deeming client, we have to get their approval Then we send the application along with all the extra information needed, and we send it directly to the district office for Medicaid. Once it hits their desk, they have 90 days to review it. Sometimes it's more, sometimes it's less. It depends on what's going on at the time, and Medicaid is Medicaid. So next slide, please. Okay, once they're approved, this is a little information that you may need, but once we get an approval, we put dates in the computer, we upload all the documents, and then I hand the file over to Crystal, and she then assigns it to a case manager, and that case manager visits the client monthly. Medicaid is very, which I love about them, they're very serious about case managers going into the home. Although I go once, the case managers go out and visit this client monthly. They are in charge of monitoring their health and services. We are not nurses. We can't necessarily diagnose or whatever, but we can tell by the questions we ask whether the client is declining in health or improving in health. And at that point in time, we need to make a decision on if we need to adjust the hours around the person-centered care plan. If sometimes people fall and break a hip and they make a great rebound. Well, we may go from total bed care to the client is walking with a walker and can do more for themselves. So that would be something that we would address and change along the way. The case manager often asks, or always asks, how many doctor's appointments, med changes, to constantly make sure that they stay in the approval area. They also assist them with resources because sometimes they don't have transportation. They may need a wheelchair. They may need extra assistance with a power bill, water bill, and we are there to help them get those resources that they need, because all of it combined can lead to somebody going to a nursing home if they don't have the adequate services or the adequate resources in the home to keep them there. That's pretty much all I wanted to discuss with you guys. If you have any questions, please feel free to ask me, because I may not have been very clear or left a few things out.
Again, good morning. My name is Crystal Smith, and I'm the Quality Assurance Manager with Middle Alabama Area Agency on Aging. And I'm going to touch on some of the stuff that Donna has already spoken about in a little more detail. And at the end, I'll give you time for questions. So y'all, come up with any questions you want to know if we don't hit on something that you're interested in. I'm going to speak specifically about the elderly and disabled waiver first, and then I'm going to touch on a couple other waivers. But like Donna said before, we provide specific services through the END waiver. Case management is provided to everyone, whether they're with a direct service provider or on personal choices. Everybody gets a case manager. And like Donna had said, the case manager, we provide just the ongoing, making sure all the paperwork's done, making sure that the services are being provided. We go out every month and see that client to, lay eyes on them and try to, ascertain if something's going on that they haven't told us about. But we also try to assist them, if they need food stamps, if they need anything else, we try to get those things for them. The homemaker services, as she said, it's, help with the housework, help with running errands, those kind of things. Personal care, the help with the bath, changing incontinence issues, those kind of things, the respite she had already mentioned. But we also have companion services. Companion services, one of the things that we run into a lot of our clients are very isolated and alone, and they need somebody to talk to. They need somebody to spend time with them. They may need somebody to go with them to their doctor's appointments because they don't remember everything that their physician tells them. And so the companion services is designed to assist with that, as far as it's somebody to go in and just spend time with them, go to their medical visits, to take notes and make sure that everything's, kept up with. We also provide meals. These are provided through GA Foods, and they're frozen meals. They're delivered one time a week. but they can get up to 2 meals a day. It's a 7-day, the box has 7 meals for 7 days. They can get just a lunch meal, or lunch, dinner meal, whichever one they want to use it for, or they can get lunch and breakfast. They cannot get the breakfast by itself, but they can get a lunch and a breakfast. This can help them save money. These are easy meals to cook. They can be cooked in the microwave. So it just makes things very much easier for them, and they are very balanced and nutritious. So one of the things that people don't realize with these, though, is that these are made across the board. So they're not going to have a whole lot of seasoning, but they are not specialty meals. They're not specifically diabetic meals or specifically, low vitamin K or anything like that. They're going to be general. And so the person has to agree to, watch their diet themselves. Also, one of the services provided through END is Adult Day Health Services, which is like a place for them to go during the day while their caregiver works or, handles other issues. Next slide. Again, back to the 2 ways that the services are provided: the direct service provider, and we contract with several different agencies that provide the services. They all do a good job. They are, like she said, they are all monitored, and they do background checks. They test their employees for TB, all those wonderful things before they send them out. And then the personal choices program, they choose their own provider. So it takes that third person out of the situation. The payment comes from our financial group, but the client or their representative is actually the employer. So they're going to do the hiring and the firing. It puts the responsibility back on the client, but it gives them a whole lot more freedom. When you're dealing with a direct service provider, you're trying to schedule a worker around multiple client schedules. And a lot of times they only want to work Monday through Friday or whatever. But when it's a personal choices situation and you've hired somebody that well, they may be willing to come to your house after hours. They may be willing to do services on Saturday, which, is very difficult to find with a direct service provider. So it really opens up the possibilities to give you more choice and more ability to manage your own services. Next slide. Okay. Once they're approved, Donna lets me know, and I will assign them to a case manager, and the case manager calls them. It lets them know that they're approved, starts getting things rolling to get them set up with a service provider. They are required to go see them every month. During the public health crisis, we did, some phone visits versus face-to-face just because of, COVID. But typically it is a face-to-face visit every month so that we actually lay eyes on that person. We can actually know. And we look for things, we really look for bruises. We look for, does it look like this person is being mistreated? We look at all of that to help ensure safety. Next slide. And again, there's no age limit to the EMD waiver program. We have had everything from babies all the way up to 105. These services are based on disability, and it doesn't have to be only seniors. So the services, it's the same services, and sometimes we have to word things a little differently when we're talking to them versus asking about falls and stuff, because you expect a toddler to fall a little bit when they're learning to walk. But we do serve a vast group. Next slide. And again, we get referrals from all over the place. It may be family members, it may be doctors. We get a lot from medical facilities. We get a lot from other programs. Even our other programs will refer to us when they, have someone call in for SHIP, or when the other programs, they see that they, qualify for us. We often refer other members of a person's family. We'll go in and we'll meet, our client, and we'll notice, well, their spouse also needs a program, and we'll refer them over. So we'll take referrals from anyone. They just need to contact our office. Next slide. And again, how to refer the M4A direct line, the 670-5770 or 1-800-H line. That is specific to the area that you live in. That's statewide. If you're calling from Calhoun County, that's going to refer you to the area agency that handles Calhoun County. We cover Blount, St. Clair, Chilton, Shelby, and Walker. So anybody in those counties that call that 1-800-H line, it's going to come to us. They will automatically go through our intake process, which will send them to a ADRC specialist, and they will, look through and see what they qualify for and refer them over. But don't worry, when you're making a referral, if you are not completely sure that they're going to qualify, don't worry about that. Go ahead and send them, because we screen them. Our ADRC specialist not only screens them for waiver, but they screen them for a gazillion other programs and anything that we can help them with. So even if they don't qualify for waiver, they may qualify for help with their medications through Senior RX, or help with food through the senior nutrition program. So go ahead and refer them. We would rather, talk to them and provide what help we can. Next. All right. Like I said, the elderly disabled waiver is our largest waiver. We've got, goodness, probably close to 600 clients just in our area. The ACT waiver is much smaller, but it is a waiver that we handle, and it is growing. What it is, it's the transition waiver for people who are in the nursing home, because nursing homes have their place and they do, wonderful things when they're necessary. But we don't want a client in the nursing home who doesn't want to be there. Someone who, has a place to go, or, would thrive better at home. There are, people who just, they go to the nursing home and they just don't do well. So this waiver takes people who are in the nursing home, and we help them come back out into the community. And they get basically the same services as the E&D waiver, except they get some extra stuff like help with supplies. And as they're coming out of the nursing home, we can help them with the cost of moving into their new location. Like if they need help with their electric deposit, or they need help, they need a ramp, or they need some specialized equipment or home supplies. Like maybe, they've lived in the nursing home for a couple of years, they no longer have towels and sheets. We can help them get some of those supplies and help them move out so that they can live at home again. And then most of the time, the ACT waiver, they tend to have a higher care plan. They get more services because they have been in the nursing home, so they're typically more needy. And they tend to get first preference, like with the personal choices. That's a very structured program as far as when they come out and talk to you about getting on personal choices. They start, the following month on the 1st. But with the ACT clients, they can start immediately. So it's very, we try to push them to the forefront because they are much higher need than the E&D typically. Next slide. And the hospital to home program, now this is brand spanking new, so I don't know a whole lot of details about this. What I can tell you is it's going to act a great deal like the ACT program, other than they are going to be transitioning from the hospital to home. And whereas we normally have to start an assessment with the client at home, the initial case manager is going to be able to start the assessment while the client is in the hospital and get that whole thing set up before the client comes home. And then they'll be able to get basically the same services as that, the extra help and, help with the ramps and all that kind of stuff. So it's going to be a really good program. It is just now kind of getting off the ground. We actually have several in training today on that program. So I don't have a lot of details other than it. From what I hear, it's going to act much like the ACT waiver. It's going to be good. Next slide. Oh, that was the end of my slides. Okay. So there are multiple different waivers. We don't handle all of them. There are, I think there's 8 or 9 different waivers, and different agencies handle them, like the developmentally disabled waiver through mental health. And but we handle the E&D, we handle the Act, and Employee doesn't actually have any TA, but the umbrella, the Alabama Department of Senior Services and the area agencies do handle the TA waiver, which is the technology assisted waiver. But all of those waivers, you know, our basic belief system and design is we want to keep people in their own homes and let them age in place, because most people would rather, you know, stay at home with their own things and their own family around them. So that's our goal.
All right, thank you so much, and thank you guys so much for working with us, for bearing with us with the screens and the slides. And thank you, Donna, and thank you so much, Crystal. Your presentations were great. Medicaid waiver is a great program. I worked as a Medicaid waiver case manager for a couple of years, and seniors really do love the services. They love to see the case managers coming. They love to see that help that comes into the home to help with their daily living skills, you know, bathing and, you know, grooming and, you know, running small errands and just helping to, you know, keep the home up, you know, especially when they're in a position where they can't do it. So it is an awesome program. So if you guys know of anybody that can benefit from these services, please do give M4A a call, give us a call, or your local area agency on aging a call, make a referral, and go from there. If you guys don't have any questions, like I said, I want to say thank you again to Ms. Carlette, and thank you, Maria. And also, if you don't forget, your CEUs should be, your paperwork should be turned in 24 hours after this webinar, and you should turn them in to humanresourceoptions.com. If we don't have any questions, thank you, and you guys have a good rest of your morning.